Hi everyone. My name is Johnny Low. I will be chairing the this coming session. So in this session, we will have 5 talks, and each talk will be 5 minutes long. So when there's only about a minute left, I'm going to just interject quickly, and just to let the speaker know that there's only a minute left. So please wrap it up. So we have a couple of presenters from Perth. One will be online, and a couple from Hobart. And our first presenter is Daisy, if you don't mind coming up here. So her talk will be on, excuse me, the development of a novel perioperative respiratory risk management optimization tool using statistical evidence. Take it away, Daisy.
Hi, how's it going, everyone? I am Daisy. I work at the Anaesthesia Research Team at Perth Children's Hospital, also known as the Perioperative Care Team at the Kids Research Institute Australia, also known as the Institute for Paediatric Perioperative Excellence at UWA. Our team is led by Professor Britta Regli von Ungern-Sternberg, who is an anaesthetist and professor of and chair of pediatric anesthesia at UWA. And our statistics section is led by Dr. Nazim Khan, who, if you studied stats at UWA, you probably had him as one of your lecturers. And today I'd like to talk to you about a proposed project that our team is working on. Now, for some context, we love a tortured acronym in the anesthesia research team. All our studies are named after animals to try to get kids interested, very kid-friendly names. So this study is called Dormouse, Development of a Novel Perioperative Respiratory Risk Management Optimization Tool Using Statistical Evidence. Bit of a mouthful. There we go. So for some background, around 18,000 children undergo general anaesthesia every year at Perth Children's Hospital. That's about 1 in 20 kids in WA. And 15% of these experience what's known as perioperative respiratory adverse events, or PRAE for short. It's the anaesthetist's job not just to put the kids to sleep, but also to manage their anxiety leading up to surgery and to make sure that their airways are safe and help prevent these perioperative respiratory adverse events. And there's a couple of things that anaesthetists can do to prevent PRAE or to manage them safely if they do come along, because although most of them are managed pretty safely, a couple can lead to morbidity and even mortality. So how can anaesthetists predict which children will be affected? And you can see my boss, Britta, there, listening to the heart of a little baby girl. How can she tell if that little baby girl is at a high risk of a perioperative respiratory adverse event or not? So there's a couple of scores that anaesthetists use currently. The ASA score, the American Society of Anesthesiologists score, is frequently used, where anaesthetists assign the health of a child a score from 1 to 5. And it's used all the time in pretty much every centre, but it's not actually designed for perioperative risk stratification. It's used really often for want of something better. There's a couple of other scores there. The STUBA score, sleep trouble breathing and unrefreshed score, only really applies to kids with like sleep apnea and other sleep breathing problems. The cold score is really only for kids with a current or recent cold or flu. And there's 2 more recent ones that I've highlighted, the Subramanian score and the apricot model, using logistic regression and machine learning. Now these were fairly rigorously produced statistically, but they're basically never used in clinical practice. Reason being, it's really hard to transfer and translate a score from research to practice, especially in something as serious and with such a high risk factor as pediatric medicine. So we propose the development of a new tool that not only incorporates rigorous statistical methods, but also really listens to anaesthetists and clinicians and uses the variables and factors that they know to be related to a child's risk when they're having surgery. So this is our proposed Dormouse score. We haven't decided exactly how we're going to make it yet. We're going to use a couple of different methods and see which is the most acceptable to clinicians. But we're pretty sure that we're going to want to make a Bayesian network of some kind, which is a really, really good and applicable way to develop a risk stratification score for for clinical use because it's really easily interpretable by clinicians, and it can also incorporate potential interventions to help prevent an adverse outcome. The problem is making a Bayesian network or any other kind of predictive model that can be translated to clinical practice is a huge amount of work. I don't expect you to be able to read this, but this is just sort of my brain trying to figure out the steps that we would need to take just to even get a tool to the testing phase, let alone implementation into clinical practice. It's a huge amount of work. We need a method that is both statistically valid and interpretable and acceptable to clinicians. And the main thing is that we can actually translate it to clinical practice. So if anyone's ever done anything like this before, I'd really appreciate your advice. My email address is on the screen here. I'd like to thank my team and, of course, the study participants and their families who participate in our research. We couldn't do it without them. Thanks very much, everyone.
Thank you, Daisy. Our next presenter is Marnie. So her talk will be on the causes and consequences of white matter hyperintensities in the brain.
Hi everyone, I'm Marnie. I'm a PhD student here at Curtin, and I'll just be giving you a little bit of a rundown on my proposed PhD project, which is causes and consequences of white matter hyperintensities in the brain. So a little bit of background. White matter hyperintensities are brain irregularities that are detected by MRI, and they're increasingly prevalent with age. They are associated with an increased risk of stroke and dementia, and their clinical implications vary by their location. For example, periventricular lesions are associated more with an increased risk of cognitive decline, whereas the deep lesions are associated more often with an increased risk of mood disorders such as depression. They're known to be highly heritable, which suggests a significant genetic underpinning, and this variation in genetics may help explain the clinical differences of the clinical outcomes by their location. So the project rationale is periventricular and deep, they share risk factors but have significantly different underlying genetics. And understanding the relationship between these risk factors, genetics, and the effects of white matter hyperintensities is crucial in helping develop treatments and improving health outcomes. So my project, I have a few aims, but I've cut it down to just 2 for today. So I'll be aiming to undertake a genome-wide association study and post-GWAS analysis to investigate the specific genetic variants associated with the white matter hyperintensities. And I'll also undertake a Mendelian randomization study to determine any links between the white matter hyperintensity risk factors and disease outcomes. So the purpose of a genome-wide association study is to identify the specific genetic variants or SNPs which are associated with periventricular and deep white matter hyperintensities. And we do this by analysing millions of SNPs for associations. So after quality control, we'll use phenotype, genotype, and covariate data, which will be obtained from the UK Biobank, and run an association test with a linear regression model assuming additive genetic effects. From this, we'll obtain a list of significant SNPs along with their effect sizes, which will be used in further downstream analysis, such as Mendelian randomization studies. So the purpose of a Mendelian randomization study is to assess the causal roles of genetics in white matter hyperintensity formation. This is effective because it reduces confounding by using the genetic variants as proxies for the exposures of interest, which we call instrumental variables. So in a Mendelian randomization, there's 3 key assumptions to be taken into account when designing your experiment. So first of all, the instrumental variables need to have a strong association with the exposure. They need to have no direct on the exposure, on the outcome except for via the exposure. and they mustn't be associated with any confounders. So we'll use the list of SNPs obtained in the GWAS, and we'll use the F statistic to assess the power of the SNPs, and we'll remove any that are low powered. To estimate the MR, we'll use various methods such as inverse variance weighted and MR-EGA, and we'll use Cochrane's Q to check the heterogeneity. And the results will be reported as odds ratios. So this hopefully should give us a better idea of the relationship between exposures such as hypertension or diabetes and the outcomes such as white matter hyperintensity formation. So in summary, white matter hyperintensities are common in our aging population and have been linked to serious health outcomes such as stroke and dementia. GWAS and MR are effective tools for investigating underlying genetics and their links to diseases, and insight into the causes and effects of white matter hyperintensities is crucial for disease prevention and treatment. Thank you very much.
Our next presenter.
Give me a second to turn it.
Hello. Yep. Our next presenter is Ling Zhan, I believe, aka
Yep.
Nicole.
Yes.
Are you ready to share your slides?
Yes. Thank you very much. Let me share my slides.
So Nicole's talk will be on automating statistical methods for detecting problematic data in randomized controlled trials in medical research.
Yeah, thank you very much. Hello, everyone. My name is Nicole. I'm a PhD student as well as a part-time research fellow at the Department of Obstetrics and Gynecology at Monash University. Thank you, ECSSC and the Statistical Society of Australia today for this opportunity to present our work on project titled Automating Statistical Methods for Detecting Problematic Data in Randomized Controlled Trials in Medical Research. So this project is led by Professor Lau Gurn and Professor Ben Moore, and here are also the names of my colleagues. And a quick glance of conflicts of interest. So what is the problem? It's long been assumed that published peer-reviewed papers are based on genuine data, but that is actually not the case. It's been estimated that 30% of data in medical papers are actually untrustworthy and potentially fabricated. And that is very problematic because these untrustworthy data would find their way into meta-analysis, which would misinform clinical guidelines and medical policies. And this could be very harmful to individual health as well as public health. And in today's presentation, part one, I will give an overview of the statistical methods that's been used to assess the trustworthiness of RCT data, as well as a sharing of an exploration of the potential to speed up this assessment process using AI large language models, actually ChatGPT. So part one. Here are some statistical methods that we have been using to detect untrustworthy data in RCTs. To start with, data copying between tables. And on the right hand side, you could see a figure of two tables, and they're actually tables coming from two different medical papers, two different RCT clinical trials on completely different topics, but from the same author. And highlighted in red and green, you could see there's highly overlapping of values. It's either identical or by just one digit difference. Secondly, we have the violations of Benford's law. So the Benford's law asserts that the leading digits are likely to be small, and therefore the digits 0 to 9 do not follow a uniform distribution if you actually pull them all together. Then the last digits, whereas are expected to follow a uniform distribution. And back to this slide. So implausible distribution of summary statistics, aka Carlisle's method, it says that if randomization has been conducted properly, then the distribution of baseline characteristics in the groups created by randomization would be the same. And fourthly, multiple statistical errors. This is quite straightforward. That is, test statistics or p-values reported are not reproducible from the displayed summary statistics, as authors have simply just taken the data from other sources. And last but not least, overrepresentation of even numbers. This is something I find to be quite interesting when I first heard about. So surprisingly, some problematic data papers have tables where all or almost all numbers are even. And the reason for that is possibly because frauds is simply double numbers from existing real data sets. That is in Excel, they copy the real rows and then paste them at the bottom. And to make the numbers look different, they just multiply all the numbers by 2. So just to pump up the sample size. And the challenge is papers are published every day at a pace that it's very challenging for assessors to keep up with. And current tools for detecting these problematic data in papers are very time-consuming and labor-intensive. To give you a better idea of what I mean, this is a spreadsheet created by Dr. Nick Brown, which me and my colleagues have been using in the past. So we would manually extract data from the tables and papers and then transfer the numbers into these Excel spreadsheet, where there are some predefined columns with formulas written to recalculate test statistics and p-values. Then we could compare those calculated by us with those reported in the paper to see if we find anything dodgy or simply they are not matching up.
1 minute, Nicole.
Yep. Yes.
1 minute left.
Oh, okay. Yep. So part 2. I will quickly share about what we've been doing using AI large language models to speed up this process. So we've been using ChatGPT, and I think that's quite relatable as everyone might have used it to some extent now. We uploaded a PDF paper and asked ChatGPT to extract all data tables in the paper and format as Excel. And I was able to perform this task very quickly in 20 seconds. And it came back with a data table in Excel at the bottom. And comparing it with the original table, we could see that the numbers have been accurately extracted and the table structure remained intact. So it's doing very, very well. And then we could import that data table from Excel into a pre-written statistical program such as R and carry out all the tests that I've just mentioned. And future implication of this work is that we could potentially create a software using OpenAI API integrated for fully automated workflow, starting with automated data extraction followed by statistical testing. And of course, we will do further testing to see how other large language models compare. So references, and thank you very much for listening.
Hello. Thank you very much, Nicole.
Thank you.
Very eye-opening talk. Very disappointing to hear that the data are being fabricated. So our next presenter is in Hobart, so Pei Xuan. Start sharing the screen. Great. Everyone can see it. So Pei Xuan's talk will be on implementing the estimated framework in physiotherapy trials. Please go ahead, Pei Xuan.
So hello everyone. Today I'll be talking about implementing the estimate framework in physiotherapy trials, and this is a work I'm currently working with my colleagues here. So to highlight why we should use estimate, I would like to use this modified version of a published physiotherapy trial called Better Knee, Better Me. And this was a randomized parallel trial investigating the effectiveness of telehealth exercise intervention with and without weight loss diet on the primary outcome of changing knee pain and physical function at 6 months. And this trial had potential intercurrent events, which were events occurring post the randomization. And for example, participants may undergo knee surgery post the randomization, discontinuing exercise, or use pain medication as needed during the intervention. And here, I would like to focus on one intercurrent event, which is use of pain medication as needed. So imagine if a patient takes pain medication while receiving the treatment, it raises questions to us. So what treatment effects should be estimated here? Should we consider the treatment effect regardless of the pain medication use, in the absence of pain medication use, or should we estimate the treatment effect in patients who would never use pain medication? So as a result, having these intercurrent events and those questions in the trial can lead to unclear treatment effect estimates, less informative stats analysis, or even misinterpretation of the results. Therefore, the estimate framework was designed to address these issues by precisely defining the treatment effects of interest and aligning the study objective, design, conduct, and analysis. So the International Council for Harmonization introduced this estimate framework in the ICH E9 addendum, which outlines the sequential process that begins by translating or extending the study objective into an estimand, which then guides study design and conduct. And we then select an appropriate statistical analysis, which addendum refers to as the mean estimator, and then we get the numerical results we want, which the addendum refers to as the mean estimate. So as you can see here in this framework, the second step is called the estimand, which is defined as a precise description of the treatment effect reflecting the clinical question posed by a given clinical trial objective. And there are 5 key attributes to use when constructing an estimand. And you may find it very similar to the well-known PCOP framework, but the estimand has a greater emphasis on identifying and handling intercurrent event. So the ICH E9 addendum also outlines 5 strategies to handle intercurrent events. And here I would like to use treatment policy strategy and hypothetical strategy as examples to show you how we can establish an estimand and what's the difference between those strategies. So starting with the treatment policy strategy, this strategy considers intercurrent events as part of the treatment. So which in this case, we assess the treatment effect regardless of any pain medication use. And that means we will use all observed data up to the primary endpoints in our analysis. And this strategy closely relates to the intention to treat principle that we usually use in our clinical trials. But we should be careful that this strategy is most suitable for handling intercurrent events that occurs in both the trial and in routine practice. And now we can put together the 5 attributes that I mentioned before in the table like this. And since our intercurrent event here is closely related to the treatment condition, so it will have to be incorporated into the treatment condition attributes as well as the intercurrent event handling attribute.
1 minute left.
But in the hypothetical strategy, we assume the intercurrent events would not occur. And in this case, we estimate the treatment effect if no pain medication is available to the patient. And in this case, any outcome data after pain medication use should be set to missing or not collected for the analysis purpose. And this strategy is suitable for handling intercurrent events that occur in the trial, but not in the routine practice. And we should really consider the plausibility of the hypothetical scenario when using this strategy. And again, when you construct an estimand for this strategy, you can use the table like this. So in summary, the estimand framework aligns objective design, conduct analysis, and interpretation. There are many possible estimand for a set of objectives in one study, but you should select an appropriate estimand depending on how you intend to use the study results. There's no right or wrong estimand, but one estimand may have to be defined as primary, and you should use clear wording of estimand to enhance the clarity of what is being estimated and improve its clinical relevance. And thank you.
Thank you, Page One. And our last presenter for this session is Cameron Patrick. And his talk will be on the comparison of methods for estimating treatment efficacy under incomplete compliance data. Cameron, please take it away.
G'day. Hi, everyone. I'm Cam. Thank you so much for that introduction and for reading out the title, which is a bit of a handful. So I'm going to break it down a bit and give a bit of a backstory as well. So first of all, I want to acknowledge my PhD supervisors, Kate, Margarita, and Tom, as well as the Australian government and Austrim for giving me money so I can have a roof over my head. So the work that I'm looking at is related to clinical trials in scenarios where you may not have perfect compliance with the treatment. So common examples of where this can occur are physiotherapy and nutrition, and I've got case studies from these. This is one of the case studies I'm looking at is a trial called Capacity, looking at lung cancer patients who are receiving physiotherapy exercise rehabilitation sessions after the surgery for cancer. Primary outcome here is a continuous measure of quality of life, and there's a measure of compliance with the treatment here, which is the number of sessions that the participants actually attended with the physiotherapist. And so there were 12 sessions for full compliance. This was then dichotomized for the purposes of interpretation into sort of compliant or not, depending on whether they'd attended at least 70% of the sessions. There are additional measures of compliance as well. There was also a patient-reported exercise diary, which is whether or not they'd done the exercises which the physiotherapist had asked them to. This data was even more complicated and had a large amount of missing data. So in the sort of most straightforward way of thinking about an RCT, we can draw a DAG that goes from like random assignment to the treatment to the outcome. And the great thing about random assignment is that we know there are no confounders here. And if we were interested in, thanks Peshan for introducing the estimand framework, if we're interested in the treatment policy estimand, this would be all we need. But often in practice, we're interested in what is the effect of actually complying with the treatment. So now we've introduced an additional variable, which is whether or not you take the treatment that you've been assigned to. And because this is not purely randomly assigned by the trialists, like you can't go and force somebody to take the intervention, there's the possibility for confounders. So one example of a confounder from the capacity trial is the living situation. So people who are living independently by themselves or with relatives were far more likely to comply with the trial than those in a nursing home. And we're going to simplify this. We're looking at nobody in the control group gets the intervention, compliance is binary, and non-compliant, like it's a placebo or a passive control, like non-compliance with the intervention is the same as being the control. And so there's a couple of estimands that we could be interested in here. One is the hypothetical estimand, which is what would happen if all of the participants complied with their assigned treatment. And another interesting estimand here is the principal stratum strategy, which is what is the treatment effect in the people who would comply with the treatment if they are assigned to it? And there's a bit of a gotcha there because in the control group, we don't know who these people are. So I did a simulation study asking what is the best way to deal with missing compliance data when estimating treatment efficacy in these two estimands when you've got missing data in a binary compliance variable. So this is
one minute left.
This is the DAG for the simulation study. So we've now added in missing values in the compliance variable. We've assumed an unmeasured common cause with that and the outcome, and also auxiliary variables like, for example, educational attainment in this study was related to both whether or not you would take the intervention and whether or not you would have missing values in the compliance variable. So this ended up being quite a big simulation study, and we looked at a number of common missing data methods and estimators for this. We can see here that everything, this is a plot of relative bias, everything performed well apart from complete case analysis when you had missing at random. Instrumental variables performed worse than the other methods. Standard errors were about the same no matter what form of methods you used for handling the missing data. And interestingly, we had multiple imputation had confidence interval coverage that was a bit too low, whereas inverse probability of missingness weighting had interval coverage that was a bit too high. We also found that instrumental variables had higher interval coverage than other methods. So thank you for that, listening to my whirlwind summary of what we found out about dealing with non-compliance when there's missing data in the compliance variable. And if you've got any questions or want to know more details about this, then please let me know in Slack.